top one is more active than the lower one. So,
Okay, yeah.
so just a little. My talk is geared a little more towards urologists and residents, so I'll try to kind of explain it. So, but basically, we wanted to do something that shrinks the prostate so it doesn't obstruct the urethra as much. But at the same time, we don't want to cause a lot of damage, because the more damage you cause near the urethra, the more burning this patient's going to have afterwards. It's going to take a little bit longer to heal up. And so what we want to do is the optimal distance from the urethra is about 1 centimeter. We've had some issues where if you go too far away from the urethra, you can create a cavity, like basically like a hole in the prostate. Now, for most cases that wouldn't be an issue, but we had one complication where an individual came after the treatment. He was peeing better, but just had this chronic discharge. So he would complain that I just have this reddish kind of fluid that just keeps oozing out from time to time. And so you can imagine that's pretty disconcerting, you know. At first we thought it was just from the surgery, but after a few months it was still persisting. So we did a cystoscope on him, and what we found is that it created a little bit of a channel, almost like an extra space in the prostate. And the dead tissue there was just kind of sloughing off and being discharged. So we treated him by just removing that tissue with a TURP procedure. That's a transurethral resection of the prostate, where we go in and just scrape out the tissue. And you know, that fixed the issue, but how can we do this better so that that doesn't happen? And what we found was that you want to be just about 1 centimeter away from the urethra, because then what happens is, as that tissue dies, it's going to open up the urethra, or if there's a cavity there, it's going to join the urethra. So that way you have a nice open channel that they can pee through. So then you get that optimal outcome. So one of the things you want to do is be about 1 centimeter away from the urethra. If you're doing this simply for enlarged prostate, you can customize the treatment for the patient. So let's say there's a young guy who comes in, he's nervous, doesn't want to be there, is taking some medication for his prostate, but he wants something done, but nothing too aggressive. Like the whole idea of surgery scares him. So what's nice about this technology is we can adjust the amount of energy that we deliver, basically the amount of ablation or killing that we're doing in the prostate. So in this situation, what we would do is just do 2 posterior ablations near where the blood supply comes in at the 5 and 7 o'clock of the prostate, around the urethra, kind of at the bottom, and that should be sufficient. It's going to take a few months for that tissue to die off and open up, but he's going to get through with very minimal side effects, and sometimes you can get away without even leaving a Foley catheter in. So the Foley, we like to use it during the procedure, and for our procedure today, I will be putting a catheter in so we can see the urethra very clearly, and that will allow us to then calculate where to put do the ablation. After the case, if it's a standard BPH case and we're doing 2 locations, 1 on either side, generally speaking, we recommend leaving the catheter in for about 1 week. So that allows the tissue to heal and they don't have any urinary difficulty. If we do 4 locations, so let's say this is a huge prostate, over 100 grams, they have a median lobe, this guy's been having a lot of urinary issues, then we have to be a little more aggressive. So on the BPH model, we would do 4 spots, 2 below and then 2 anterior, and I'll kind of illustrate this when we actually do the case, so it'll make more sense in terms of exact locations. If it's prostate cancer, the same way this tissue kills the tissue for BPH, it's also very good at killing cancer cells. So if it's a patient who has localized prostate cancer just in one area, we can do something called targeted or focal therapy, where we place 1 needle right into that area, and it creates a nice 2-3 centimeter ablation zone around it, so we can effectively treat it. When we're dealing with cancer, if it's a larger prostate and very deep, we may do 1 pullback. A pullback is basically pulling that laser back about a centimeter so you can get like a double ablation. So basically along the whole length of the prostate. And I'll kind of illustrate that when we do the case. What's really nice about prostate cancer applications, we can do whole gland ablation if they have multiple spots of cancer in the prostate. You can basically ablate the whole prostate if you need to. But what is really nice about this technology is, since we're using ultrasound, we'll use Doppler to actually look at the area that's being ablated. It's really cool. It's one of the few modalities where in real time you can see the tissue changes in the prostate. And on Doppler, you can actually see the tissue reactivity. So what's really nice is most of our treatments for prostate cancer, we don't get that kind of real-time feedback. So this, you can actually see the area that you're ablating. And then, most importantly, you can look at the neurovascular bundles that are important for erections on either side of the prostate real time. You can see the flow there while you're doing the treatment. So that makes it very, very powerful and effective because you can see all the structures you don't want to touch, and you can see where the cancer is and where your ablation is, and really control the amount of energy you deliver. So these are the two applications for the laser ablation. I'll show you like a quick little video about how we do the setup. Now, before I get to that, just some clinical outcomes. It is being used off-label right now for prostate cancer. There's early data on this. We've done about 120 cases right now. We initially used to use the CLS system, but now we've switched to the Rocamed. That's what this system is. It's a little more effective, and you get more tissue reactivity, so that makes it easier to do the treatment. We use ultrasound to assess the treatment while we're doing it, and that's what we'll use today. And then post-treatment for prostate cancer, we check their PSA every 3 months, and a year later we'll do a biopsy to see if we got everything, if there's any residual disease. Or if the PSA goes up sooner, then we'll do that biopsy sooner. So what do our results look like so far? This is a review we did a few months ago. There's 103 men. Basically, we categorize them into low risk, intermediate, and high risk prostate cancer using the NCCN guidelines. In the low risk patients, about 88% of these guys were essentially treated. And what we mean by that is that their biopsy 1 year later came back negative. So we got their cancer. We define the failures as basically 4% of the guys had a recurrence of disease in the same spot we treated. So in these individuals, we treated them again. And then 8% of them were actually spots that developed in a new location. So let's say we treated the left side of the prostate. A year later, they come back in the biopsy, there's a little bit of cancer on the opposite side, but the area we treated was negative. So it's not a true failure, but definitely what we call disease progression. So in these individuals too, we come back and ablate them in that new location. But what's impressive here is that it does not affect their erections, and 0% of the patients had any incontinence issues. When we go to intermediate risk, similar results, about 96% success rate. When we look at high-risk individuals, this is a very interesting group. So these are guys who have Gleason 10 prostate cancer. So classically, we would recommend radiation, surgery, hormones, the whole shebang. But if you're 50 years old, right, and you have a great sex life and you're totally dry, that's a tough and bitter pill to swallow. So what we're seeing nowadays is that many of these younger men don't want to have aggressive treatment. So we have a protocol now where we do 2 years of hormones, but we do laser ablation. And what's interesting is in this group, if we fail, then we do radiation and surgery. But so far, what's impressive is 70% of these guys are biopsy negative 1 year out, which is incredible, because we've never had an option like this for men in this situation. Now, the understanding is on this protocol is that they fail, then obviously we'll have to do radiation or surgery or more aggressive treatment. In that group, we just had one individual who developed metastatic disease. Unfortunately, with Gleason 10 prostate cancer, we think that your destiny is already written out, and the likelihood of developing mets, unfortunately, is high. So especially in that group of individuals, something like this might be more helpful because we can at least provide them a good quality of life. And that starts to become pretty important with cancer survivorship. In terms of erectile dysfunction, there are no new cases of erectile dysfunction. What we mean by that is nobody started out perfect, had the treatment, and lost their erections. But we had some progression of ED, so there were about 3 or 4 guys who had some baseline erectile dysfunction and it got a little bit worse after the treatment. And then no incontinence at all, and the average time the catheter was in was about 10 days. We're being more aggressive now. Nowadays, if we're doing focal ablation or small glands with DPH, we're trying voiding trials, and many of these guys are not having a catheter. So you can really kind of push the envelope quite a bit with this technology. But what does this look like? What is the actual treatment? Sorry guys, why it's not.
We have 3 cases, but I presented 2 first cases we're going to do today. The first patient we have is a 46-year-old patient, male patient with diabetes and visual impairment, and he has symptomatic LUTS with an IPSS of 25 and MSHQ. It's a questionnaire about ejaculation. He's 11 and the normal is above 12, and IEF of 24. So he has a small prostate of 37 grams and a PSA of 0.29. On digital rectal exam, he has a grade 1 prostate, firm and elastic, no nodules, and cystoscopy have a bilobar prostate enlargement without prominent median lobe. He is on alpha blocker use for over 1 year, and these parameters are in use of the alpha blocker therapy. He has a Qmax of 8 and post-void of 90 milliliters, and urodynamic study bladder outlet obstruction. And this is ultrasound. This is small prostate. This is the bladder. No median lobe. And the second case is a 66-year-old patient. He has hypertension, symptomatic LUTS, but not too severe as the other one. He has an IPSS of 12. He has the ejaculation okay, and the erectile function no problem as well. The digital rectal exam has a grade 3 prostate, 67 grams, a PSA of 2, 66, the straining bladder on combined therapy for over 2 years, and he has uroflowmetry of 12 Qmax and post-void reserve of 190 milliliters. This is his ultrasound. He has a bigger prostate. I don't know if it's going to be a problem for the.
No, these are beautiful cases. So both are really nice. I think for both of these, we'll probably just use 2 fibers,
Okay.
and that should be pretty straightforward. Really nice ones.
I want to show the third case. We can do this. Oh, okay.
You can see how just doing a little bit of activity lights it up. So I think where that is like actually over here. Still be in the prostate. What happens is that laser is so floppy that if you pull the sheath outside the prostate, it's almost impossible to get it back in because the fiber is so flimsy it can break. So you'll see I'll always leave about 1 centimeter of length of the sheath there, and then we'll look at the ablation. That should be more than enough. So that's just a little nuance to kind of remember. Then we're going to do the same thing on the other side. Sorry about that stool, and now we can see the outside. We're going to do the same thing here. We'll take the next. The top one is more active than the lower one, so I'm going to give the lower one a little love buzz. See the difference?
Okay, yeah.
See, just a little, I don't know if there's